Hey, good morning, everyone, and welcome to our first webinar in our Women's Health Matters series. My name is Dr. Nazanin Homaifar, and I'm an assistant professor of OBGYN or obstetrics and gynecology at UCSF, and the director of patient education and health outreach through the UCSF National Center of Excellence in Women's Health. We've had a variety of webinars in the past year, and we've created Women's Health Matters to address common questions and concerns specifically related to women. And when I speak about women, I want to acknowledge that I'm using this term not only to address cis women, but also trans individuals, non-binary individuals, and/or anyone who expresses their gender in a feminine way. Today, we're honored to have Dr. Eleni Jaswa and Dr. Lori Pash join us from the Center for Reproductive Health on a conversation about egg freezing. Many of you have heard of it, and some of you may work with companies that offer benefits to assist with the process. I know I regularly get questions from friends, families, and from patients. As an OBGYN, I will often have initial conversations about the topic with my patients and then refer them to a reproductive endocrinologist and infertility specialist, or an REI, like Dr. Jaswa, for a more detailed conversation. We're hoping that many of the common questions that people have today will be answered with this webinar. While we wait for others to log on, please help us get a sense of your general knowledge or experience on the subject by answering the poll questions that have been published. While we give you a chance to respond, I'd like to introduce our wonderful panelists and give you insight as to how we will use the hour. We have Dr. Eleni Greenwood Jaswa. She is an assistant professor of reproductive endocrinology and infertility, and she's also co-principal investigator of the ASPIRE research study that is currently ongoing. We also have Dr. Lori Pash, who is a psychologist and professor in psychiatry and behavioral science. Welcome to you both. Thank you for joining us on this Monday morning. Bertina, can we publish the poll results and get a sense of who we have joining us today? Great. So I think 70% of you know a friend or a family member who has gone through the egg freezing process. And it's interesting to see that, you know, while we often think about the benefits of the process, there's a lot about it that we don't often discuss. So 23% of you reported that this experience for a friend or family was overall positive. 38%, about 40%, said it was a neutral experience for people. No one reported a negative experience, but there are 40% of you who don't know anyone who's experienced the process. So we hope to give you a little bit more insight today and talk about how to, if it's something that you're interested in pursuing, how to psychologically also think about it as well. As I mentioned, today we'll focus first on learning the basics of egg freezing from Dr. Eleni Jaswa. She'll also answer questions on the ideal candidates for egg freezing and general cost. And then we'll talk to Dr. Lori Pash about the psychological effects of the process and how to approach it. Many of you have sent great questions ahead of the webinar. We've reviewed them and we'll be addressing many of them during our questions. And for those of you who may want to rewatch or share with other friends at UCSF or outside of UCSF, the recording will be available online in a few days on our website, and we'll send you the recording. We'll try our best to leave 10 to 15 minutes at the end for questions. But now, without further ado, because there's so much to cover, I'd like to start with Dr. Jaswa. Dr. Jaswa, it seems like in the past decade, we've heard much more about egg freezing and have seen big companies provide benefits for it. Can you tell us a little bit about the history of egg freezing?
Of course. First, I just wanted to thank you, Dr. Homaifar, for having us on your webinar today. This is a topic near and dear to both of our hearts that Dr. Pash and I think and talk about for all the time for many years. And so we're really happy to be sharing some information that we hope is helpful for decision making. The history of egg freezing, first, like the idea behind freezing anything is to slow down biologic processes and pause the clock. This is really important for female fertility in the setting that women are born with every egg they'll ever have, a lifetime supply. And so as women age, there's a decline in the quantity and also quality of eggs, which has been more and more recognized and is contributing to reduced fertility into the later 30s, early 40s. And so the idea behind freezing eggs is to freeze these cells at such a cold temperature that basically biology stops and preserve future fertility in the event that you need help in the future. Egg freezing has been around for decades. The first baby born from a frozen egg was born around 1986. Before that, there was a long precedent actually with sperm, which is a lot easier to obtain, obviously, but as it applies to eggs, it's been around since the 80s. And with the improvement in technology, we see improving success rates, and that's what prompted this technology in the United States, at least, to be declared no longer experimental as of 2012. And that really marked an inflection point of many more women and patients coming to use this technology.
And 2012, and so that was when the American Society for Reproductive Medicine, or ASRM, which is like the leading professional organization in the United States for endocrinology and infertility, came out and made this seminal statement, correct?
That's right, exactly, 2012. And that was really prompted by technological improvements. You know, here we are sitting in Silicon Valley in 2021, and reproductive medicine is really a high-tech field, and we've been the beneficiary of some technological advances. So what really happened was an older way that we froze eggs was using something called slow freeze. They now are able to flash freeze eggs, and because eggs are really big cells that are delicate, have lots of water, there was trouble in the past with success rates. This new flash freeze technique really afforded success rates comparable to freezing embryos, for which there's a longer precedent. And that's what kind of turned the idea on the status of the technology as no longer experimental.
Fascinating. And so I think we'll talk about maybe at the end the difference between freezing embryos versus eggs, because I know there has been some thoughts about those, and you've helped clear it up. But you mentioned a little bit about fertility decline. Can you give us more information? When exactly is that happening? What are the implications for patients?
Absolutely. It's a key question and the foundational question behind this whole conversation. So women are born with every egg we'll ever have. It peaks actually when our mother is pregnant with us as a fetus and declines thereafter. That's the reality. And this is, I always tell patients, in stark contrast to men's biology, where with every heartbeat, 1,000 new sperm are made. So night and day, there's no sperm reserve. We talk about ovarian reserve, but not really sperm reserve for the most part. And so women's fertility really peaks in the 20s. And obviously, biology is in one place, and society, the way we live our lives, has really outpaced that. And so we think of egg freezing as the potential bridge. To put some rough numbers on it, peak fertility in our 20s is probably up to 20-25% chance in a given month of regular unprotected intercourse of getting pregnant. And with the decline in egg quantity and quality, by the time we turn 40, that number is maybe about 5%. So
5% chance of getting pregnant with unprotected sex each month at the age of 40.
You got it. And that's all a reflection of just declining fertility potential. The eggs age with every other cell in our body, and that puts them more at risk for being unable to divide into a healthy embryo with the right number of chromosomes.
Okay. You started telling us a little bit about that. This is, I think, well, actually, before we talk about egg freezing, I do also want to set the stage, because I do think what I've experienced as an OBGYN is that late in the past few years, the conversations about future fertility have increased. But I think from the messaging we get from the media, from consumer brands, like sometimes it feels like we're being, yes, we want to face our fertility, but it's scary. I do feel like there has been some fear mongering about, like, know your fertility potential. What thoughts do you have on that? And like, what should we say? You know, you talked about biology versus society. How should we think about that?
It's a really great question, and Dr. Pash probably can weigh in on this as well. But at least from a medical perspective, there's a lot of unknowns. You don't know. The best test for fertility, honestly, is unprotected sex. And until you give that a try, we don't really know. It's just a matter of time. If you're less than 35, a diagnosis of infertility is established after a year of trying without success. If you're over 35, that timeline is shorter, 6 months of trying. So it's challenging in the setting of inability to predict the future. Certainly there are some medical issues, tubal disease, history of certain infections that can increase the chance of a fertility issue and might warrant getting checked out sooner. But in a normal, healthy young woman, you don't really know till you try. I totally hear you. I mean, I think in some situations, egg freezing can be used, like you said, inappropriately with marketing based on fear and kind of taking advantage of women. And absolutely, we don't support that. I think women should have what information they can have to make a really informed decision about if and what is right for them and their family planning. Lori, I don't know if you have any further thoughts about kind of the fear element or what you see in the community about that.
Yeah, we really just have to fight against responding to the fears that come from marketing, et cetera. I mean, I just think one of my most important things that I always want to say is that egg freezing is a great option for some people, but it's just one tool towards family building and is very personal. It's not for everyone. Not everyone wants to do it. Not everyone can do it. And there are a lot of other ways of making your family.
It's a really important point.
I think that's a great way to segue into what the process looks like and who is the ideal candidate. So thank you for making my job easy. Dr. Jaswat, can you tell us a little bit about what the process looks like?
Sure. So in general, the intense part of the process is a couple of weeks. It always starts with a long conversation with a physician to talk about all the risks and benefits and estimate success rates specific to an individual. But when it comes down to the bread and butter of what does my life look like while freezing my eggs, in general, the intense part is about a couple of weeks. It involves
2 to 3 weeks or 3 to 4 weeks. What would you say?
On average, 2. I'd
Okay.
say on average 2 weeks. And there's a lot of different ways to approach it, but in general, it means giving yourself shots each day under the skin, in the belly, 2 or 3 shots a day for an average of 10 or 12 days, during which time you're coming into the fertility clinic for frequent monitoring appointments, where you get transvaginal ultrasound, an ultrasound in the vagina to look close at the follicles that are developing. Follicle just means a fluid-filled structure that supports an egg. And so we're monitoring the progress of the eggs developing with ultrasound and blood tests. So women can expect, an average of 5 or 6 visits over 10 to 12 days, 20-minute visits, quick ultrasound blood test. And then ultimately, at a certain point when the eggs are likely mature, there's a final injection that precedes the egg retrieval or harvesting procedure, which is done 2 days later.
And that's often called the trigger shot.
You got it. You'll hear a lot about trigger shot. It's the important timed shot. And that's because it starts that kind of meiotic maturation for students of biology that dictates when the eggs will be mature prior to release or ovulation. And so folks come back at UCSF. We do it in our clinic. We have our procedure room. The procedure itself takes 20 or 30 minutes. Women are sleeping during the procedure, feel no pain, and then are up and on their feet within an hour after that. So that's kind of what life looks like as far as commitment to being at the doctor's office goes.
And when they go into this procedure room for the egg retrieval, you said they won't feel any pain. What kind of anesthesia are you, and I know CRH is going to be different from other places, but what would CRH give for anesthesia?
Yeah, great question. So in general, it's done with IV sedation. So an IV line, intravenous line, goes in the arm and gives you medication. We have an MD anesthesiologist who attends all of our cases and keeps you safe, breathing on your own, no tube down your throat or anything like that, but breathing on your own in a sleep using IV medicine.
And do you ever give medication through the cervix as well, or local anesthesia, or no?
Not for this process, no.
Okay, good to know. And so many of you have probably heard of this IV medication as conscious sedation, or I hear people mention twilight sedation, which is somewhat similar, but, and then you wake up from it, you go home. Is there, in general, when would you say someone is able to go back to work after the process?
Yeah, in general, it's a really well tolerated procedure in the sense that most people are functional same day. That's the one day we require you to take off work just because, you know, doing engineering or whatever you do with anesthesia in your body's never a good idea. But typically most patients go back the next day unless there are any kind of unanticipated complications. But most people are feeling fine and functional within a day.
Can you mentioned some, the potential complications. What are some general complications of the procedure?
Yeah, I think that's really important to talk about because obviously nothing has zero risks. Risks are quite low, but what I tell all of my patients is the way egg retrieval and egg freezing works is by trying to get you to mature and ovulate more than one egg a month, which is more typical biology. Our typical biology, when we're not on birth control, not on hormones, it involves a communication between the brain and the ovary that picks a single egg of a pool of eggs available that month to grow and ovulate. That's why humans tend to have one baby at a time, not a litter like cats and dogs, thank God. And also for you who delivered my one baby at a time, not having to pull out 10, we're both grateful for that. The way egg freezing works is the shots you're giving yourself are the same hormone that your brain uses to communicate, but now in a much higher dose. So instead of having one egg available, we rescue the other eggs that would have died that month. Maybe it's 10, maybe it's 15. So the ovaries are stretched, and with that, expect to feel bloated, expect to feel crampy, that's common. When the ovaries are stretched and making more eggs than usual, they're also producing high hormone levels. So I tell all my patients, expect to feel, hormones are a very powerful drug. Some people feel full of life and energized. More people, I'd say, feel really tired, moody potentially. Just let it be. It's hormones. It's temporary. Acknowledge that, I think, from the start. Some of the more serious complications of egg freezing are really quite rare. Some of the more serious complications include something called ovarian hyperstimulation syndrome, OHSS. This occurs quite rarely and tends to be in women who respond too aggressively, make many dozens of eggs, and can have some complications related to that. Another complication we always theorize about, but really is quite rare, is something you know very well, Dr. Homey-Fair, as a gynecologist, ovarian torsion. When the ovary is large, it has the potential of twisting on its own blood supply, cutting off blood flow. That's a painful surgical emergency. This is extremely rare. I haven't actually seen it during the stimulation itself, but we ask patients mostly to kind of avoid the berries boot camp or really high impact stuff, take it easy, gentle exercise while the ovaries are enlarged. And then just procedural risks. As you know, whenever you stick a needle anywhere, you think about risks like bleeding or infection. This is less than 1% of cases, and we're pretty good at preventing these complications, but they occur.
Thank you so much for that. I think it's just so important for people to go into something. I think we can all immediately think of potential benefits of a procedure. If you want an IUD, it's a great form of contraception. It can help with periods. If you want to do egg freezing, you can potentially bank eggs for the future. But we don't often focus on what the process is going to look like realistically, and also what, even though the chances are extremely rare, what those complications are. So I appreciate you taking the time to highlight those. So who do you, this is a loaded question, and I know it's not one size fits all, but who is the ideal candidate for egg freezing?
Yeah, it's a really great question. And just like you said, obviously, there's no blanket statement. I think some rules of thumb for your average healthy individual include, basically it's a risk benefit trade-off. In your 20s, probably may not need it. In your 40s, maybe certainly the efficacy and cost effectiveness is down. And so, women in their 30s most generally. And so what I always think about is the younger you freeze your eggs, the more likely you are to be successful with them. But at the same time, the less likely you are to ever actually need them, because you've got so much runway, reproductive runway in your future where you might meet someone or want to start a family on your own and still remain relatively, spring chicken from a reproductive perspective. And so it just kind of depends. Now, certain people may say, well, I'm 34, I want 7 children. And that would guide me differently than a 29-year-old. I'm not sure if she wants children at all, but everybody kind of weighs their algorithm of likelihood to require them with importance of being a parent differently. And so those are some general considerations.
So one thing that I heard from you that's important to highlight, it would be helpful to have an understanding of how many children you may want.
Yeah, I think so. I mean, there's scenarios in which you might get pregnant on your own for your first baby and be reproducing into your 40s and really want another child and have a harder time then. So there's a lot of different scenarios in which these might become helpful. And I think Dr. Pash, it looked like you had something to add to the ideal candidate scenario question.
Oh, I was just going to add, of course, I'm not the physician, but if you have any medical problems, right, that could kind of come into play, or you anticipate having any, like if there's a family history of early menopause or something like that, that might trigger, I should have a conversation.
Yeah, absolutely. So all of those kind of benchmarks were for no reproductive health issues, no real health issues, but certainly there exist a variety of medical issues that might predispose to early menopause. Mother's age of menopause is actually a good predictor and pretty heritable trait. And so that, or if you've need ovarian surgery over and over, if you've got one ovary, other reasons to suspect that you might have a shortened reproductive window. And this is always worth talking to a reproductive endocrinologist if there's any unique situation, or even your OBGYN about kind of planning. It's really, to me, in a way, the opposite side of the family planning coin, in the sense that the birth control pill did wonders for women's reproductive autonomy and options. This has many dissimilarities, but it's kind of the other side of that coin, is thinking about how to safeguard reproductive autonomy in some sense and options.
Absolutely. And I think, so on the flip side, you briefly mentioned this, but like at what age in a woman's life does egg freezing no longer make sense?
Yeah, it's really hard to draw a line in the sand because everybody's so different. So I've seen women who are 43 who get 1 egg per cycle and unaware that might be a 2% chance or less of a baby, for whom the biggest benefit is having done everything they could to keep that option open, even if it's a really small chance. And so as long as there's an informed conversation about it, I think people often will regret not having done it younger, but not the other way around. And so that's just one of the kind of the nature of the beast. I think I wouldn't draw a firm cutoff, but certainly cost effectiveness is reduced after 40.
Okay. I think I saw something a few weeks ago from someone who, like so many of us go through our lives in our 20s kind of blissfully unaware of our fertility or doing things to avoid getting pregnant. And I always make this joke with my patients. It's like we focus so much on not getting pregnant that when the time comes to get pregnant, we're like, how do I do this? Like, what's my menstrual cycle? But I had someone make a comment saying that like she had a really difficult, unexpected infertility journey, and she wishes that in her 20s she had frozen her eggs. And I paused because I was like, I totally get that, but I don't know at the same time, like, do we think everyone should freeze their eggs in their 20s preemptively? How would you respond to that?
Yeah, I mean, I would say no in as few words as possible, but it's more complicated than that. I mean, certainly we've seen it, and Dr. Pash has led a lot of big studies about the distress of infertility. Many women say they'd rather have cancer than infertility. We grow up thinking, as you said, that having your genetically related children is your birthright. And kind of the educational system does a disservice by, I got the impression that if you look at a man the wrong way, you'll get pregnant, as opposed to thinking, wait, this is actually really hard to do down the road potentially. And so we don't plan so much for pregnancy as so much we plan against it. And so generally in the 20s, you know, like I said, and on average, there's still time for children. And so it would take many women to freeze their eggs and never use them to probably help a single woman who's in a unique scenario, who has an unanticipated early fertility decline. Really, the risk of menopause before 40 or primary ovarian insufficiency is like 1%. And so, you know, keeping an eye on your menstrual cycle, if you're off the pill, other just routine health checkups hopefully are enough, but it's not right for everyone.
And so I think one thing I always try and, like, when I'm listening here, like, what's a pearl we can leave the audience with? And one thing would be, you know, have a conversation with your family if you have access to them, if they're willing to share. See how difficult the journey was for them, to get a better sense of, are there things like 1% chance of premature menopause or primary ovarian insufficiency? I think that's going to be very, you know, people don't need to worry about it, but if you find out that there is some significant family history, that should prompt a potential conversation and look into what you might want to do.
Absolutely. I think that's exactly right, is instead of kind of being afraid to bring it up or ashamed or nervous about what it means, just tell your OBGYN you're thinking about future fertility. Talk about it.
And what I would add to that is that if you don't like the answer you get the first time, or you didn't feel like the question was addressed really well by whichever provider you asked, ask another provider. Don't let years of your life go by without checking in.
That's really important.
I think on just going back to the egg freezing process, you briefly mentioned this, but maybe going into a little bit of detail, like what can someone do in preparation for egg freezing? Do they need labs drawn? Is that something that their OBGYN can order, or do you prefer them coming to you first?
Yeah, there's not much that prep that you actually really need. One nuance is that many women have been on, for example, the birth control pill for decades. In some women, that kind of makes their ovaries go into hibernation, and they end up needing to come off it for a few months in order to establish their normal baseline to have as productive an egg freezing cycle as possible. Now, this isn't to encourage people to go off and have unintended pregnancies, but just to be aware that if you're like many people who've been on the pill for 30 years, for 20 years, it's possible that coming off of that for a few months might boost your egg store. Not for everybody. Other than that, really the kind of assessment to predict what you might gain from a single cycle of egg freezing is an estimate of ovarian reserve from a quantitative perspective. What I mean to say is there are blood tests like AMH, for example, or more importantly, when you end up coming to a reproductive endocrinologist, an ultrasound to look at what the ovaries look like, how many eggs might be there in a given month, and really be able to forecast the potential utility for you as an individual, not as an average 34-year-old, for example.
Great. Yeah. And I think that AMH, I try and tell, I feel like I have this conversation weekly because people want to know what is their fertility potential. And this has been a lab that's kind of been used at times inappropriately to predict that. But the key is that this AMH is something that you, as a reproductive endocrinologist and infertility specialist, would use to help guide some prediction of success with the success being like a sense of how many eggs you might be able to retrieve from the process, but is not a tool that we should be using to inform your ability to get pregnant on your own.
Super important distinction. It is a metric only for your chances through a super physiologic, through this like egg freezing specific context. It does not tell me if you try to get pregnant, what's your fertility. It is not a fertility marker.
Thank you. Thank you for that clarification. So what if someone is living in SF, working in Silicon Valley, wants to undergo egg freezing, but thinks they might end up elsewhere in the United States when they might want to use these eggs? Should you be freezing your eggs in the place that you might potentially use them, or what can be done to access them?
Great question. So these are material that can be shipped and are shipped all across the country, potentially the world. Really the safest thing to do, and we encourage people to do this, is to thaw and use the eggs wherever you froze them, only because every lab is different. There can be storms that delay shipping. There can be, you are subjecting your preserved gametes to some risk when you're transporting them, but it's absolutely easy to do and done all the time. We do encourage you to use your eggs where you froze them if you want to mitigate all of those kind of risks.
Gotcha. And is there a certain amount of time that eggs can be frozen, or do they, I know you said you freeze them in time, but like, is there any potential for aging or making the quality less?
It's a great question. In theory, these molecular motion is like so slow that these eggs should remain usable, vital for far longer than you would ever come back for them. And what I mean to say is if you freeze your eggs at 35, you're not going to want to come back for them in 40 years to use them for a pregnancy, but certainly they will get you covered for your foreseeable reproductive future without any, as far as we know, reduction in quality.
You mentioned that some people might need to come off their birth control pills during the process, but let's say someone has an Nexplanon or an IUD. Is that something that they need to remove prior to the egg freezing process?
Really great question. And luckily, that's a totally different ballpark than the birth control pill. We don't see it really as the same kind of suppressive effect. And you can keep your Nexplanon, your IUD in without impacting your egg freezing cycle. We do that all the time.
Oh, great. Okay. So have a comment. So you can go in, you don't need to have it. With the Nexplanon, I wasn't sure. We know the IUD is not consistent in suppressing ovulation, but it's just important to bring it up with your REI, but you can keep it in place, which is wonderful because those are long-acting reversible forms of contraception, and to be able to keep it in is a bonus.
For sure.
Does egg retrieval decrease your chance of getting pregnant on your own?
Really great question. The answer is no. We are not taking away from your ovarian reserve. These eggs that are captured and frozen would have just died away on their own that month. The ovary recovers great. The reserve is not affected. And so this in no way impacts your future fertility.
And if someone wants to conceive on their own, but wants to freeze eggs, do you have any guidance on the order of timing? This is one of the submitted questions we got.
Yeah, in general, well, I don't know if the question is, should I freeze my eggs and then try to get pregnant, or try to get pregnant then freeze my eggs? If that's the question, the thing to think about is just, hey, I'm 35 now. If I have a baby when I'm 36, next time I'll be trying for baby number 2, if that's important to me, is 2 years later, 38. So kind of trying to fast forward, knowing that it only gets more challenging to get pregnant over time. Now, if you have no history of infertility, that might be a different scenario. It's really hard to forecast for any given individual, but I always, just be aware of the delay that a pregnancy might cause you if you're really insistent and really important to you to have a very large family, for example. Another scenario that people sometimes ask about is, I'm older, I have frozen eggs, haven't yet tried to get pregnant, do I use my eggs or try? And I always, even though I'm an IVF doctor, encourage women to try on their own, despite the risks that accompany, older eggs. I think in general, nature's a pretty good sorter and has had a lot more time with evolution to get pregnant in our own bodies than, IVF, the oldest person is 42. And so if you can get pregnant in your own body and save this non-renewable resource of frozen eggs in the bank for the future, that's what I always encourage for ordering.
Very helpful to hear. And is there any data on the negative health effects of hormone exposure during ovarian stimulation?
So this has been looked at for a long time, and there are no increases in risk of some of these hormone responsive invasive cancers. So no increase in risk of invasive breast cancer, invasive ovarian cancer, and that we feel a lot of global literature supports that. So it's a safe thing to do from that perspective, even in people who might have an increased risk for a breast or ovarian cancer, such as our BRCA carriers.
Yeah, that's so important to highlight. So this is not for people who have hormone sensitive cancers, who have concern about stimulating their ovaries. There are no long-term effects of this 2 to 3 week regimen that we might put someone in, or if someone wants to do multiple cycles.
Yeah, even though the hormones are high, when you think about the cumulative dose exposure compared to a pregnancy, this is a drop in the bucket. So the estrogen and progesterone are high, but nothing like 9 months of estrogen and progesterone, which we know doesn't really increase risk of those cancers either.
Great. This is why I love doing these panels, because I just learn different ways to talk about like how other people are counseling and think about it. And it's always so useful.
It makes me wonder, are there even guests here, or are you just using us for some? It's just education, peer-to-peer.
Personal education. Yeah. We haven't gotten any questions yet. I welcome, hopefully our attendees are getting their questions answered, but I do encourage our attendees to let us know if they have any questions. I see a hand raised, but you can, for whoever's raising their hand, if you want to submit in the Q&A, you're welcome to. And if you're having trouble with the Q&A, please let us know. Dr. Jaswa, I know I'm mindful of the time and we still need to get to Dr. Pash, but one of the really important questions that comes up is about the cost of a cycle. So I know, you have a billing department that handles this, but can you tell us a little bit about the cost?
Yep, it depends really, and you can always call and get this information, but it depends on insurance coverage, et cetera, versus self-pay. There's different rates. That being said, a ballpark estimate for egg freezing, which you should think about as the first half of an IVF cycle. If you return for eggs, you're doing the second half of the IVF cycle. But egg freezing ballpark is probably 10,000 plus another 5,000 for meds. So it's not cheap. Unfortunately, this is an ongoing issue for access for a lot of folks.
And so do you know in general, like, will insurances cover the cost, or is that an individual conversation people have to have?
An individual conversation, you probably know if your insurance covers it. It's a benefit that a lot of the larger companies in the area are starting to offer increasingly commonly. But in general, regular health insurance, including, for doctors at UCSF, it doesn't cover.
Mm-hmm. And what about, I know there are in certain states for people who might have a new diagnosis of cancer and might need to undergo chemotherapy or radiation, they can be fast-tracked. I think if anyone, this is also very rare, but if anyone has any questions about that, California is a state that is currently offering egg freezing, I guess, is it at a totally reduced price, or do you happen to know?
Yeah, I don't have numbers, but there are definitely more resources for that. And it's absolutely worth a phone call and a consultation. Those we have a team at UCSF, for example, specifically focused on that, who makes it a priority to get those people seen within 48 hours. So that's really important to be aware of.
Okay.
It's a difficult situation for sure.
Good to know. And we'll give some resources at the end. We were just talking prior to the webinar, there aren't really that many patient-centered resources on this process, but we'll offer 2 websites that can give you a little bit of information if you need any. Dr. Jaswa, last question. How should someone less than 35 think about the number of cycles needed to get 1 live birth versus someone over the age of 35?
Great question. It's very individual and hard to predict, but there are 2 main ingredients, and there are modeling studies that your doctor can look at with you to help make a prediction. So it's really like age plus number of eggs per cycle, and that can give you an approximation of 70% chance of at least one live birth. Of course, being in its relative infancy as a technology deployed for this specific indication, we're getting more data as we go, but you can get a pretty good idea with your doctor. There are certain like graphics that will show you, oh, I froze 15 eggs and I'm 37, that puts me on X percent. And that's useful for just thinking through that's good. I'm happy with one cycle, or maybe I'll do another cycle and up my odds. Always more eggs, increased chances, but there's also never a guarantee, which is the other side of that coin. Many women will ultimately return for these eggs and not be successful having a baby. So that's really important to keep in mind.
Okay, and I just want to acknowledge I wasn't able to see the questions, but now I do, yeah. And we'll get to those at the end. But many of these we've been able to answer. Dr. Joshua, thank you. We're going to come back to you at the end. I'd like to move on to Dr. Lori Pash. Dr. Pash, you've been an integral member of the Center for Reproductive Health for almost 20 years.
Yes.
Can you tell us a little bit about your role?
Yeah, well, fertility treatment is just really unique. It's not only a medical treatment, it's also about like helping people build families. So while the physicians are focused on mostly about like what's the likelihood of pregnancy, medications, what's the goal for them is pregnancy. My role is to help people plan for and build families in a way that they're going to feel good about and to support them in the process. So I meet with any patient who wants guidance or support in navigating fertility treatment. Some of the common things I work on are deciding whether to do it, what treatment to do, how to prepare, dealing with emotional responses, coping with disappointment, dealing with family and friends, what to say to them, what not to say. And then I also spend a fair amount of my time helping people prepare for alternative methods of family building, like egg donation, sperm donation, adoption, surrogacy, and all that.
So does every fertility clinic have someone like you? Because I think this is such a huge part of like making decisions in this process.
Definitely not. Most fertility clinics do not. I mean, almost every fertility clinic has a list of potential providers that are in their area, but it's actually one of the things we're working on in the American Society for Reproductive Medicine is making access to mental health care more easily available to patients. And we have done some research on that showing how important it is.
That's fantastic. And I think, yeah, being UCSF trained and a physician here, I think I've gotten used to you being here and not realized that it was such a unique role that you had. How do you interact specifically with patients who are interested in egg freezing? And do they see you separately or on the same day as they see the fertility specialist?
Yeah, so I have seen this whole trajectory over the course of the time that I've been in the practice. When egg freezing, when we first started offering it, when it was brand new and still considered experimental, I met with every single patient to help educate and prepare them. Now, as egg freezing has become pretty routine, I just meet with those who want extra guidance or support, and they can just tell their nurse when they're getting their initial labs and process getting started with the process done, that they would like to have a consultation with me. And what are we talking about? Some people, who are the people who want to talk to me? Basically people who are nervous about their future fertility, but they're just not sure if egg freezing fits their needs. Some people aren't sure if they want children, but they're worried that if they don't freeze eggs, they'll regret it later. Some people are in the process of gender transition and they want to talk about whether it makes sense for them to freeze eggs in advance of that. Some people are in advance of cancer treatment. Some people are in relationships. They're not sure if they're good for having children, or some people just ended a relationship and they're worried that they won't find a new partner. And then I also see some women who are just thinking, should I do egg freezing or should I start thinking about getting pregnant as a single mom with donor sperm? So when I meet with people, we're going to talk about like their broad family building goals and their personal goals, whether egg freezing fits in, steps towards building a family if they didn't do egg freezing, considering like when and what circumstances their life might be if they wanted to use their eggs in the future. So for example, like maybe they're going to conceive naturally for their first child, but feel good about having eggs frozen for a second, something like that. We talk about like feelings during the process, what to tell family. Each one of these consultations is very unique. It has to do with that person and their goals.
And are people at this, I know I'm getting into details, but I think these are such important conversations. At the Center for Reproductive Health, can people make an appointment with you before seeing a physician like Dr. Joshua, like REI like Dr. Joshua, or is it you have to go through the REI first and then meet with you?
Well, that's a good question. I mean, generally speaking, it happens that they see one of the REI doctors first, and then if they want to, they could talk to me. Occasionally it happens the other way, and people can just call the Center for Reproductive Health and make an appointment just with me because they're thinking about some issues or concerns related to the topic, and we can talk about it first before they really get into the nitty-gritty with the doctor.
Helpful to know. What can patients do to mentally prepare for the process of egg freezing?
Well, it really depends on the person. Some people find this to be a pretty easy and straightforward process, and other people find that they feel really anxious or sad or lonely. And here's a couple of tips. So the way we talk to ourselves has a big impact on how we feel, right? So it's very important to come up with a way of thinking about it. Basically, like, what are you going to say to yourself during the process that will provide some kind of comfort and feel empowering? Like, I'm doing this, it's a good choice, I'm taking some kind of action, doing what's in my power towards my future goals. Also, it's really important to think about what else is going on in your life. So be sure to plan your egg freezing cycle for a time that's reasonably calm in terms of work and other obligations. So it's a pretty intense process time-wise, but only for about 2 weeks is the intense time. So you want to think about making a space for yourself where you can focus on remembering to breathe and focusing a little bit on self-care during that time.
So important. I think this is a leading question, but you and Dr. Joshua published a paper in 2018 about decision regret following elective egg freezing.
Yes.
Tell us a little bit more about the findings.
Yeah, we're really committed to learning from our patients about their experiences. Dr. Joshua mentioned I have done a lot of research with infertility patients about their experiences so that we can be better prepared to support them. And so we're doing the same thing with people that are doing egg freezing. So our 2018 paper is about how women feel a few years after egg freezing. So we're really glad to report that the majority of people felt really good about it and felt they were glad they did it. But a concern that came up from this research is that a substantial subset, about 16% in our study, had some significant regrets about their decision. And so, the burning question is, well, what did they regret about it? Definitely the number of eggs they were able to freeze is related to having regrets about deciding to do this. So what that means is if the process doesn't go as well as they'd hoped and they end up freezing a relatively small number of eggs, people feel like it maybe wasn't worth the money they spent. Some people feel even more concerned about their future fertility than they did before they did egg freezing. So that's an important thing to know. And also we found that people who didn't have enough information or support as they went through the process were more likely to have regrets, which is part of our motivation for having this conversation with you today, so that people feel like they were really able to get their questions answered and they didn't feel rushed in any way. In addition, there's some people who report just a range of difficult emotions. Some people feel kind of lonely or sad during the process because it kind of brought up disappointment about not having found the right partner yet, or not having been financially ready for children and having to postpone. So overall, I think the process for some women is kind of like a wake-up call, makes people think about themselves and their future and their goals and what's important in a way that maybe they hadn't done so before. So what does that mean is that, overall women tend to feel really good about it. But for some, it doesn't feel like a simple sort of insurance transaction, like I'm just going to put these eggs in the bank, but it's a little bit more complex from an emotional standpoint. And it's really important to have supports in place.
I mean, this is so important to highlight because I do think the general way we discuss egg freezing has always been a positive way. Like, look what we can do now.
Yeah.
Look, like we can take control of our fertility. We have access to these benefits. And I think, yes, absolutely. Like these are all really important, but what's not being discussed as much, what's being discussed more in small circles or individually with providers is like, I didn't realize what this process would be like, or I didn't realize that I could end this process disappointed. And not to say that is not the common theme, but it's still, you said like 15 to 16% felt that. And I think it's important to understand that going in. And so Dr. Pash, I guess this is not, are there any questions that you think people can ask when they go in for their visits to give them a better sense? And Dr. Jaswood, this is for you too, about, what they should expect for themselves in the process. One attendee asked, like, can you, something about can you do an ultrasound and have a sense of how many eggs you might get? What, if you were telling a sister who is about to go in to meet a new REI to talk about the process, what questions would you tell them to ask?
Well, I think, we've talked about all the questions that have come up in the Q&A and that people had put in advance were really good ones. So I feel like Dr. Jaswood really addressed a lot of the main questions. And I think, to be honest, I think the biggest thing is that you're not going to quite hear it in that very first consultation, because you probably came in feeling kind of nervous. And sometimes that leads us to kind of hear certain things and like mishear other things. And so I think afterwards, it's a really good idea to have a conversation with a friend and have them ask you questions. And then are you sure you knew what you were told? Are you sure you got something from this? Like, what did the doctor say about, what the side effects might be? Because I think fairly often I see people who were so focused on one aspect of it that they didn't hear everything.
And it's hard. I mean, the tools we have to predict a response, so a blood test and an ultrasound, are really just predictors and rough estimates at the end of the day. What matters is when you start shots, what does your body do? And so I find that this is especially challenging because it's a lot of people who are used to, have great jobs at big tech companies or, have access to resources that they can do this and are used to, if I work hard, I can get what I want. And then all of a sudden it's like an exercise in loss of control, kind of like parenting, maybe at the end of the day. But for people who are used to just working hard and getting the job done, this is hard because you can't always predict, you can't always control what you'll get. And at the end of the day, what does a 40% chance at a baby in the future mean? Is that, for a lot of people, well, it's better than zero. For other people, it means spending money that they can't then do something else with. So it's so individual. And it's just kind of in its infancy of how we can best use it.
And I think I would say just in general, trying to navigate the healthcare system, some of the questions that I find useful are, what are the next steps? Just very basic, like, do you need me to go and get the lab work done? Or is someone going to call me to schedule the ultrasound? What do I need to do versus what is something, what is someone going to contact me about? And then, who is the best person for me to contact in order to get more information, so that when you do go talk to your friend and you realize there are gaps in your understanding or there are questions that you want to follow up with, you know who that point person is. I
Yeah, for sure. For sure. Just even the logistics of it, to not feel lost, to feel like I know what to do if I'm confused. I'm not alone. There's someone who's here for me. And women will tell me that. Like, I hear people say the shots were really hard, but I would get on Zoom with a friend and eat a chocolate afterwards. And that was like my ritual that made it work okay for me. But it's just really important to conjure up whatever support you do have if you anticipate, and maybe you don't anticipate, that it's more than certainly just buying car insurance, for sure, as Lori was so beautifully saying.
I think this has been an incredible discussion, and I want to get to some of the questions that have come up in the last few minutes. I think we briefly mentioned this, but just to make sure our audience hears it, what are the risks associated with and recommended timing for doing multiple extractions?
Yeah, so just to reiterate the risks, primarily it's discomfort, very rarely medical risks like hyperstimulation and torsion or bleeding related to a procedure. Probably less than 1% for all of these. And so I saw a question as well about repeated extractions, and this is deemed to be quite safe. Even the ASRM, American Society for Reproductive Medicine, looking at young women who are donating eggs for others, say up to 6 cycles is appropriate, barring any knowledge of this increasing risks for that individual.
Do you, in general, if someone wanted to undergo multiple cycles, what would you say the cadence would be for, like, how often they would when they begin their next cycle?
A lot of the protocols we use at UCSF, and every place is different, but I mentioned that 2-week intense period. There's usually a month kind of lead in where you might take a pill or a patch to kind of further optimize your cycle. So the retrieval part itself tends to be every other month if you're in a back-to-back kind of approach.
Okay.
And that is fine. You don't need to wait longer than that.
And on average, how many appointments are required for the process, and how long is the extraction process? I think I heard you say 5 to 6.
Exactly. So you'll have the consultation with your physician, 1 or 2, and then during the stimulation where you're taking the shots to grow the eggs, it's on average about 5 or 6 20-minute monitoring appointments where you're getting ultrasounds and blood tests before you have the procedure itself. And
the procedure should generally, I think you said it's about 30 minutes.
Exactly. And that allows time for falling asleep and preparing and waking up. So the procedure itself can be 10, 15 minutes, but it's generally about a 30-minute appointment.
Great. So are people in, because would you say they if they come in the morning, that they would leave by late morning, or?
Yeah, I mean, for example, our first procedure would be at 7:30. You'll be out of the procedure room by 8, probably walking home, walking out of the recovery area by 9, about an hour to recover. Modern medicine is pretty crazy.
Yeah, that's amazing. And then if you decide to freeze your eggs, one attendee asked, how is the 2 weeks plus extraction timed with your period and cycle?
So there's a lot of different ways to do it. Depends if you have a period or not, but the most common conventional approach is starting shots when you get your period. But you can really do it randomly, and UCSF has actually been part of the conversation showing that that works too. So there's a lot of flexibility that you can talk to your doctor about.
Right. And one person asked, is there a generally known ratio of number of eggs extracted to potential pregnancy viability?
Yeah, a ballpark figure I've seen is like 6% chance of a baby per egg, maybe lower for women in their late 30s. This is a little rough just because it means you have this like linear relationship where you ultimately get to 100%, and that's never the case. So it's a little more complicated than that. But for women under 35, 6% per egg has been a figure thrown out. And we can also, I don't know if there's a place we can post, but I can post a figure that's one of these models. I know there's a lot of questions about like give me my chances. And so we can post a figure that can help people see number of eggs based on age and what their chances are.
That's great. I think I've seen different variations of it, and it's just so that, these questions can be hard to answer so broadly.
Yeah.
And they should be answered with your REI, but just to get a sense. And then I think I saw that you had answered for one of the questions, but what are the success rates of using frozen eggs I guess it means
versus embryos, I think is the question maybe.
That was one of them. So one person wrote, if one freezes in 20s, are success rates using those eggs comparable to getting pregnant in one's 20s? That's the question.
Yeah, so important point is when you freeze an egg, the egg remains the age you froze it. Your uterus can age, but for the purposes of establishing a healthy pregnancy, the age of the egg is really the important thing, not the uterus.
Okay. And then last question, if it's okay, how long would you recommend waiting to try to conceive non-IVF, not using eggs, after doing an egg retrieval? Right with your next period, go for it, in my mind, if you're excited about that. There's no like procedural risks. It's just a tiny little needle point through the vagina that should heal up by the time you have your period. Mm-hmm. So that's about 2 weeks after your egg retrieval that you can start working on it. Great. So you do not need to delay future fertility or desires to get pregnant?
And definitely like talk to your doctor about it, because if you're in a unique scenario or have any complications, this could be different. But if everything goes fine, generally by the time you get your period, your body is more or less back to normal for most people, but talk to your doctor as well.
Sounds great. Well, Dr. Jaswa, Dr. Pash, thank you so much for joining us today and for lending us your expertise and your time. And thank you to our audience for joining us today and for submitting all of your questions. We will have the webinar posted in a few days with some of the resources from the American Society for Reproductive Medicine and resolve.org. I also want to thank Bertina Lee and Verndine Tortorelli at the Women's Health Resource Center for helping with the marketing and launching Zoom. We'd love to get your feedback on how we did and how we can improve our webinars, especially the Women's Health Matters webinar series in the future. So please, you will be getting an evaluation at the end. If you can submit it, we would be grateful for that. Dr. Pash, Dr. Jaswa, I'm lucky that I have your email addresses so I can email you my questions anytime. But thanks again, and everyone, I hope you have a great rest of your week. Bye-bye.
Thank you so much.
Bye.
Thank you.